kind of running a little bit behind time, but that's not to say to necessarily rush the papers. So Nico, please do accept our apologies for having been waiting for such a long time. We have had a lengthy discussion on some of the reports today, but that's still no excuse to apologise. So we're here to present the infection prevention and control report, so over to you.
Okay, so while the report is 95 pages, and it's the annual report, and I can see this was written by my predecessor, so I taken over in the month of June, and the report was prepared by April. So there is some key things, there's key issues in there, but I don't want to just focus on a lot of the negative that has been pulled out, but there is positive things that we've done as an IPC department throughout the year. So where we can see the first issue that talks about team resilience being very small, inadequate to support the trust adequately, and leaving the IPC team mainly short. And I just want to put some contents around that because I've worked in the team for probably about 7.5 years, and it was a team initially that was functioning with 2 to 3 members, and we were managing okay within the organisation. But there are there are contributing factors that have changed that has allowed it now to become inadequate, and that can be identified as things around, we had a pandemic, and there's more assurance and there's more asks of the infection control team. Also, the population has grown that we serve, and also health inequalities has contributed to that. We've also can see in global warming has been a contributing factor. So with the global warming, we can see that there's more viruses that are presenting, and we're seeing more things, as I said, you can see like monkeypox, that's become the mpox. We can see also around vaccinations. So people are not being vaccinated or having their children being vaccinated. So we're seeing things like measles and the whooping cough and so forth starting to come back, and antimicrobial resistance as well. So as people are having too much antibiotics, we are seeing that bacteria are no longer being killed off by the antibiotics. So these, with all of these things that I've said about the contributing factors, that brings a lot more work in relation to the infection control to be doing and required to work with. So that's why it's now, where it was okay with 2 to 3 members of the team, now we're needing a bigger workforce in order to assist us with that. Okay, so that's the first part. It was mentioned about the needs to ensure ownership of IPC by clinical areas. Where the Health and Social Care Act talks about that infection control is everybody's business, we know that we are a busy organisation, staff members are really busy, and it's also about them keeping that on their agenda, that infection control is also a responsibility of those. So what we have done, and this is one of the good things that we did throughout the year, is that we've put a dashboard in place. So we're not just going out auditing the areas, giving them a report and saying this is what's expected of you, because we need them to be owning, brought into this. So what we've done now is said, okay, when you do your audits on a monthly basis, and when you send that to us, we have a dashboard that will have like a RAG rating system on there, where we see areas which are below 85%. We'll call them to a meeting once a month, and we'll have that discussion, and it'll be more with like the clinical areas, so we'll have the states and facilities will be there, infection control will be there, we invite the heads of nurses and our matrons, and we can have that discussion to see what is the issue in these areas that we can do, get involved and support to correct those things, instead of just saying, the audit is below 85% and we need you to correct it. It's about having that conversation and bringing everybody to the table. So we brought that in place, and what we had to step it down as a team changed. So in the month of March, April, May, and that's going to be for this new financial year, we did have staff members leave, but we are building and we have recruited to our department. And I believe in relation to some of the other issues that's been identified around the IPC environmental audits and hand hygiene, and looking at the average and scores and consistency, that's been highlighted because of the database that we put in place. But we are working with the staff in those areas, so the managers and the heads of nursing. And it's important to say that the heads of nursing have really come on board with this and are really involved. So if we need to escalate things, the heads of nursing have really been there to support. And then I must also highlight that we've got a really good Deputy Director, Lisa Pym, who has really worked with us throughout this year in relation to bringing us into, we've got 10 criteria of the Health and Social Care Act, the Code of Practice for Infection Control, that we need to adhere to. And there were some gaps in assurance from our side. And Lisa Pym, with her governance hat, has helped us to get things in place in relation to that, and that's with those monthly meetings that they're bringing everybody together and having that dashboard. The systems are a bit clunky, but we are trying to do what we can to work towards it. I think that's the key things. I'm just thinking of time. Around outbreaks, COVID-19, we still continue to see outbreaks, but we do manage them quite well. So even when an outbreak, for those that don't know, is determined by 2 cases with what's got time and place, and it's the infection. If they've got the same infection, it meets with the time, it meets with the place that's identified as an outbreak, unless it's Legionella. If it's Legionella, if you've got 1 case, then that's classed as an outbreak. So when we have an outbreak, we put all our IPC enhanced measures in place, and we will have a risk assessment. So the risk assessment will be if the wards are closed, because our patients are not in an acute hospital where they're in beds, laying in bays. Our patients it's like a home to them. And they're all communing together, so the transmission will probably be higher. So we need to have restrictions, and those restrictions are that we do close wards, and this has not just been because of the pandemic. This is our processes from before, but we do have risk assessments in relation to who would be admitted onto the ward, so we take into account of the patient's health, their physical health. If we've got someone that's physically well, then we would say, can they be admitted to a different ward? And if they are admitted to that ward, then what can we put in place to support that service user, then being less transmissible to them to have that infection? And then in relation to our LFT, not LFT, is our FFP3 fit testing. As an organisation, you've probably seen for a few years that the fit testing results have been quite low. We did have a programme in place where with our fit testing, we've got port accounts. So previously we used to have these hoods that you put on your head and spray these chemicals. That created a lot of issues as well. And in relation to having staff passing those, the pass rate is quite low. But using the port account, the machine is a lot better, and it's not as invasive as well, because staff are not having chemicals sprayed in their face. And it's worked quite well. So what we've got is 4 port accounts that has been given to each directorate, and those directorates have been trained as well, so they've got people in place that can continue with doing the fit testing. So we did have, to start it off with, we couldn't expect those areas just to go straight, steam ahead, start doing that, but we had a project in place where Derek Tobin was helping the areas and bringing somebody in to fit test everybody, and our numbers have gone up. I'm not sure of the data today, because we have our IPC committee scheduled for the end of October, how far we've come with that, but I know that our numbers have gone up. And it's important to say that it's really important that we do our fit testing, because with the monkeypox, or the name's changed to mpox, one of the key requirements from a PP aspect is fit testing to have an FFP3 mask. And we are working, this is not the annual report, but this is going forward, we are working on putting our HCIT, so this is a high consequence infectious diseases procedure in place for our organisation, which includes about our PP, what's required. Because even though we are not expected to look after service users with a high consequence infectious disease, they will enter into our services, and we need to be prepared for at least that time of the testing and that time of them being transferred as well. So we are working on that as a team.
Great. Thank you very much. You taking over. I know somebody else actually put together this report, was the author of the report, but you described it really well, and also described what's going ahead. If I can just throw a question, and it's not necessarily what's contained in the report, but if there was one thing that you would benefit from in terms of your team, how do you think we as a board could?
I think for the big thing is, I'm going to come and say resources. Because it's something, there's so much that even within me and my team would like to do. Instead of being a reactive, we want to be more proactive. So there's a lot of things that we want to do, like educational programs that are accredited for our organisation. And when you go into the world of IPC, it's very small and nationally, and mental health is in the corner. And we would like to have mental health, especially this trust. I've worked at this trust for 22.5 years. I would like to see us on the map as a mental health organisation representing infection control.
Excellent.
Yeah, I just wanted to comment, and again, it's not in the report, but it's related to the point you just made about, so it's not just about resources, it's about having the right resources and the right individuals that understand. And I just wanted to say thank you and to congratulate you on the fact that you have made some successful appointments of people who do have backgrounds that you just described, both in terms of understanding IPC, but also having a mental health background.
Yeah.
So I think that that's a really positive thing what's going forward and is going to use it. Thank you.
Yeah.
Excellent presentation, thank you for that, and it's great to see all the great work that you're going to be doing going forward. Also fantastic to the work that you've done on fit testing, all our lessons from COVID. My question is, and I'm not clinical or from that background, but I read the report, I've read the report and I've looked at I've not read every 80 odd pages of it, but I've sort of looked at the optics around it. And I'm thinking here and now, today, if I was a member of the public, I feel quite worried looking at that. So therefore, what are the conversations, it's not necessarily a question to you, Zali, but questions to the board here. What are the conversations we're having at QPES, for instance, then, that's actually then helping you do your job and your team to do your job much more effectively? And the fact that IPC wasn't mentioned in the QPES reporting, I'm a little bit concerned that we're not joined up. So I don't know who would answer that question, but...
Yeah, I think that's really my job, in particular as Director of Infection Prevention. So the work that we've done in the last couple of months about resetting the committees that sit under QPES will mean that going forward, infection prevention does report more directly, more often. At the moment, it reports through the Clinical Governance Committee. So we had the Clinical Governance Committee yesterday, so we took the infection prevention reports. At the minute, we are a little bit out of sync, which we should be able to rectify by the next quarter. In terms of the resource, I think Lisa Kim, as the leader says, has actually done a fantastic job on this this year. There's been allocation now, not just for supporting the committee, but addressing each of those high-risk individual specialist roles that are mentioned in the report, and that's been, complex work, and these are highly specialist professionals that maintain compliance with statutory responsibilities. I think the amount of work that Zalika and the team have had to do as a result of new governance from the pandemic, the amount of reporting that has to do to NHSE is absolutely, it's huge, isn't it? It is huge, and probably through our inboxes we get more from IPC elements of NHSE than anywhere else. So there is something about how we think as a team now that the guys are really on top of what they need to do and actually have a fantastic culture around IPC, because it can be quite tick-boxing in some organisations, a bit clipboardy, and you never have a clipboard anywhere near you, which is there is something about what's the strategy now for infection prevention and how is that really felt as a positive impact by our service users. We do have some quite constrained estate, don't we? Yeah. And that's that we're aware of as a board. But I think getting now into a space where we're thinking about how do we manage the governance more appropriately, and what's the team skill set in governance so that we can free Salika and the team to be more out there leading infection prevention, and we can probably get the governments taking care of it in a different way. And there'll be a bit of work for us to get on top of that. My view would be if we developed what I would describe as an IPC assurance framework, it then gets everything in one place, and you just have one report that you update rather than having to construct working reports every month for our assurance, but particularly NHSC's assurance. And we'll probably touch base with them next spring in terms of where they're at and how they're connecting your ambitions around because on that.
So, just trying to get my head around in terms of what's something's changed obviously over the last 6 months weeks come in. So something's triggered that. So and I'm assuming then, you know, over a long period of time we've been running a risk around quality and safety and potentially reputational risk. So and that going forward, is that something that we absolutely need to recognise? I'm just thinking out loud here because I don't understand the finer detail of this, but the optics of it doesn't look good.
The risks that are identified in this annual report are risks that we all recognise, and the major risks are associated with particularly the estate where we know we've got particular issues. So I think whilst the report brings all of that together into one place, and I think Salika made the point at the beginning, didn't you? I don't really want to focus on all of the negatives because actually some of the positive things. And I think there's something about the report perhaps not being balanced. I think that was behind your coding message around this. So I think there is something about the way the report is written, creating that. But I think also it does bring together in one place all of the information that IPC holds. But I don't think it. So if we're going to ask ourselves the question at the end of the meeting, which we will, is there anything new here for our platform, for our risk? I think the answer is still no, because I think these are, you know, they're known entities that they are articulating in a way that brings that together for us in this report.
If we just say something about you're absolutely right to say about the reports. In some places we just uncomfortably. I think from a chief list point of view, in the last 3 meetings, we're aware that we're the shortfall of staff in the infection control team. And that's where we're concerned about, and also the issues in the annual report that you highlight, like lack of their quality group and other individuals. And what we've seen is some improvement, some assurance from these from the team there. But we recognise that there's more to be done. But even recognise the achievements that we've made so far today, I think. Yeah. But I mean, we always get an update report like every 2-3 months, I think.
Yeah, and it's been coming monthly at the moment as well. And it was raised as an alert in the report for that myself and Winston wrote from August, and it was noted again as an advisory on the report from September. So there is definitely oversight and increased oversight at committees now.
Thank you. If there are no other questions for Salika, again, thank you. Keep up the work. Thank you. So we're moving on with the assurance report from the People Committee, which is Sylvia.
Thank you, Chair. So, People Committee was held on the 18th of September, and as part of our AAA, the committee was alerted in regards to the current sickness levels within the trust, which has increased in comparison to last year, same time, and this year there has been an increase in the number of sickness. Some of that was concerning around the reasons for sickness related to stress and anxiety amongst our staff, which can also align to some of the statements that we heard from Sharon this morning around supporting our staff and well-being. People Committee was advised that training and coaching support for managers in terms of managing sickness and return to work was being undertaken, and that would be reported back to the committee at a later date in terms of improvements. There was assurance in regards to the actions that were taken to address the last internal audit review into our bank staff management. The committee was assured that action had been taken promptly to address some of the concerns that came out of the audit report. There was also assurance in regards to the delivery of the people's strategic goals in regards to the delivery and the monitoring of progress around that. And the committee also received assurance in regards to the support structures that are in place for the successful recruitment of our international nurses in terms of retaining and supporting them in settling into the trust from their international, coming from an international background. There was also assurance on the training that's being provided to staff in regards to accessing the e-rostering system, and there's a timeline in place of January 2025 for that training to be completed in regards to ensuring that all our staff have been trained in e-rostering. The committee was advised of an update in the activity of our women's network, which is celebrating its second anniversary of being in place in November. The network has developed some very positive initiatives for the Trust in regards to sorting our female workforce around menopause, maternal bereavement, and also with statistically women being the main carers in the home and supporting that field as well. The committee also received advice in regards to introduction of the stay conversations with potential leavers as part of our retention drive, and we're also looking at as part of this retention strategy when these will start they have started taking place, and that will be monitored and fed back to the committee in the future or future meetings. The Board Assurance Framework Committee identified the following revised risks to our BAF, which resolve around the inability to attract, retain and transform our workforce, and also the failure to create a positive work culture that is anti-racist and anti-discriminatory, which we've also touched on today. And I think that concludes our report for People Committee. If there are any questions?
Thanks, Sue. Are there any questions for Sue or Patrick? Great. Thank you. Thanks, Sue. So we call in Emma. Welcome, Emma. Absolutely expect to see you in green, all in green. Apologies for giving you away, we have run over it slightly a bit, but obviously, you know, you can take your report as read. I know that obviously I was at the last People Committee meeting where the report was presented, so this is the wider board. So to you.
Okay,
Thank you. And thank you, colleagues, for going the extra stretch for wearing green today. I know it's not everybody's favourite colour, but I really appreciate that. Thank you to kick off Speaking Up Month. So the report that I'll speak to today is retrospective and gives you an idea on the activity levels of all the contacts that we had between April and June this year. So we continue to be very busy. We had 110 contacts, and that's slightly more than last quarter, which suggests that we continue to be seen as a trusted alternative route. In the spirit of trying to support colleagues to address things at the sort of, at the lowest local level, we support our colleagues into values and practice scheme. So we signposted 2 of our colleagues to that last quarter. And then you'll see on the first graph, it gives you a breakdown of the professional type and the grouping of colleagues that seek support from us. You'll see it's quite representative actually across all roles. So to give you an idea of the types of concerns that colleagues bring, probably the highest category, because the categories that we categorise our concerns are set, they're quite prescriptive, they're set by the National Guardsman's Office. Inappropriate attitudes and behaviours and incivility always seems to be the biggest category of concern. And this is things like disrespectful attitudes, microaggressions, unhelpful communication styles, relational conflict, and unprofessional behaviour contrary to our values. And the next highest category is work safety, so the impact of that, such as stress and anxiety, the effects of bullying and harassment and inappropriate attitudes, and an acknowledgement that that actually does affect individuals' health, well-being and performance at work. So when we look across our vector baseline against other organisations and also nationally, 17% of our concerns this quarter featured an element of patient safety and quality, and that's roughly in line with last quarter, but not too far from the national average, which is about 18–19%. Bullying and harassment concerns went down last quarter by about 6 percentage points, and they make up about 16% of our inquiries against 22% nationally. And as I said, worker safety was a feature of almost 1 in 3 of our cases. Good news is that our colleagues don't tend to raise concerns anonymously. Some do, but in the last quarter we only had 1 anonymous letter or 1 anonymous voicemail, which we were able to respond to. That's quite a lot lower than you see in other organisations. So moving on to the types and themes of concerns raised, we do identify hotspots, so we do triangulate our data and feed back to the PSERV Emerging Risks Group. So we triangulate data with the legal and inquest data, safeguarding, complaints and pharmacy. So it gives us, the team, a really good idea of how the hotspots are. So to give you a flavour of, or pull out some of the most salient concerns, again, incivility and bullying is a big one. We had some concerns raised about high acuity and insufficient staffing at Coral Ward RDB. Staff unable to access exit interviews. Obviously, that is a form of speaking up, as you'll see from the address that, and the management's given assurance that that work is underway to look at that. Unfortunately, we've had some negative feedback from a range of staff that have been through a formal HR process, and some of the themes in their responses, some of those include that they've had insufficient feedback, the timelines protracted, and poor communication throughout the life cycle. And sadly, some of those have said that they would not go through a formal process again, and this was for bullying and harassment because it was, and I quote, "It's difficult to hear, it was damaging and harmful to the mental well-being and workplace relationships." So In terms of the work that we do to improve our Speak Up culture, we continue to offer our surgeries for day and night staff, and we do those across the organisation. And we're getting better at adopting an intelligence approach as to where they are. So we don't just respond to every request, we think about where those hotspots are. And we are going to be best use of our time. We continue with our induction activity. That includes a corporate activity and also the student nurse induction. And it's important for me to report progress against our improvement plan, which was agreed this year. So that details, it gives us a number of objectives which will enable us as an organisation to gain greater assurance about our Speak Up culture. So we're making progress against that, and I've illustrated some of the actions in the report. And also, finally, we've been able to adopt the NHS England policy into our existing Speak Up policy, which is a lot more accessible and a lot of it's sort of easier read for colleagues. So the work we do to make sure that our work is inclusive, as I said, we continue our out-of-hours surgery. We've received, interestingly, quite a lot of concerns this quarter from TSS bank staff. So that's really encouraging, and we've been able to feed back to the leadership there what those themes are, so they're able to address them and address any gaps they have in their systems and arrangements. We're also building really strong relationships with our practice placement team, because we recognise our student nurses are a great opportunity to come in and see things differently and to be curious and to ask questions. But they also do face unique barriers, and as you obviously most of you would have seen the AGM, you heard from Charity, who's just absolutely fabulous, a rising star, and she's going to be doing some bank work for us when she moves placement. So we continue to monitor protected characteristics of our speakers, and gives you a breakdown there. About 35% of colleagues that access Stream Speak Up have a protected characteristic, and race and ethnicity, sorry. And about 16% of our staff have a disability. So we're confident, I think, the data we've got at the moment, that we're reaching all parts of our workforce. So we have 17 champions now. One, as I said, is a student nurse, but also we've got our first international nurse, Arden Lee, so that's really encouraging. And importantly, more champions in HMP Birmingham, because sometimes that can be seen as quite sort of remote and site. So you'll see in the final section of the report, we do talk about our organisational learning, so it's really important for us to extract all the learning and the good practice that comes from Speaking Up. And colleagues at Arden Lee have put together a new initiative called Today's Outlook, which provides critical real-time information about staffing levels, updates, daily staff huddles and other safety staffing intelligence, because some of the speakers that come into us were at that time omitted from that information, but that now ensures that all information is accessible and cascaded to all staff that need to know. Lisa, our exec lead, is going to be working with HR, head of HR and other stakeholders to be looking at developing a joint professional pathway, which will focus, among other issues, on strengthening the operations and handling formal casework procedures. The team in the North completed transgender tech training. This was a really quite a delicate inquiry to deal with, but Lucy dealt with it brilliantly. The complaint was raised about actually was, completed the transgender training and felt that that was a really positive mood, as did the team. So we're assured that team, their cultural competency when addressing or working with patients has certainly improved. And then the final part of the report just gives colleagues a flavour of some of the national developments from the National Guardian's Office. That concludes my report. If anybody has any questions or queries, I'll be more than happy to answer. Thank you.
Great, thanks. Are there any questions, comments?
It's not questions, just a couple of comments. I just wanted to say a big thank you for all the work that you've done around, all of which is cited in the report, but particularly around recruiting 17 champions, because we know In the early days, it was difficult to get people interested. Utilising those individuals to support and encourage others really worked, and obviously the work that yourself and Lucy have done personally has been really helpful to that, so I think that's really encouraging. Thank you.
Thank you.
And I just also wanted to comment about, so in the organisational learning, it's good to see more and more a balance between the organisation as in corporately as an organisation taking action and individual services and divisions and departments taking action. So I think that balance is something that we'll need to look out for going forward as well.
Yeah.
Wider ownership
Yeah.
has been demonstrated, I think, through that. So thank you for the support that you've given all of those teams as well as us corporately to think reflectively about what does this mean and so what are we going to do?
Sorry, can I come in? I know it's not my time now, but and I won't be here later, but that'll be okay. Now, I think it's really important that we encourage people in their infancy and in the first employment our organisation. Very important to speak up. It is not the responsibility of only managers, leaders, etc. So I think your work that you're doing with student nurses, our internationally educated colleagues, I know that you've reached out to Elena in our division who's doing some fantastic work. So I think that's really key that we learn early on in our careers with the organisation about when somebody doesn't look right and doesn't feel right. There are avenues to speak up. Thank you.
I definitely agree, concur with that, Leona. Finally, it's really important to have speaking of Guardian's report to the board, not just because it's a tick box exercise, also a legal requirement to have that, but really we do want to hear the voices of our colleagues and let them know that they are actually being heard. So the question I have for you, is there anything more that we could do as an organisation, as a board, to support the work that we're doing to get colleagues to speak?
Thank you, Phil. I think the next sort of big push would be to us to have greater assurances of trust that our managers and our leaders are able to support a healthy speak-up culture locally. And I think that comes probably from completing, the e-learning, but also some bespoke, possibly some training and some input into each of those areas, because it's variable. Some teams are excellent, other teams that are sort of, starting on in their journey. But that will give us assurance that our managers and across the divisions all have a sort of reasonable standard, or we're sure they're working towards building a healthy speak-up culture. So I think we've had some early discussions, haven't we, Lisa, about how we might do that and include that e-learning as possibly a quality objective. Is that correct? Next year. So support with that, and obviously rolling that out. I don't understand how that would be, how that's rolled out, or how that works. But obviously, I've yet to find out. But that support with that, because it's when you talk about e-learning, it turns people off, doesn't it? Certainly people that it does, and that's a reality sometimes. So we've had quite difficulty to get people interested in it and motivated in it. Maybe that's about the training itself, but I think if we can try and bring it to life by mainly delivering it ourselves, and whatever that might look like, I think that's probably a little bit more realistic to increase the uptake. So support for that would be great, please. Thank you.
That would be thanks. There's a great machine as well. And also, I don't think you have a part in, do you have a slot in the induction panel?
Yes.
As well, which is important.
It gets mentioned a few times at different parts, but obviously directly by yourself is not by us too. I think we can do a lot around encouraging training, but I also think we can do a lot around making e-learning training motivating. So I'll give an example. The other around training is online, it's one of the best training courses you could do. And it couldn't be delivered like that in person, I don't think. So there's something about how do we learn from those really good e-learning packages about how we might, enhance the e-learning opportunity around freedom to speak up and everyone taking responsibility. And obviously this month gives us a real opportunity to promote that kind of listening but understanding point. So I think there's an opportunity for us through the senior leadership team meeting next week to be encouraging everybody to be thinking about what their pledges are. We already asked senior leaders, but also around what does that mean in practice for them in their teams around creating that culture.
Thank you. It's just about getting people to think about listening to understand rather than listening to react. And I know I've been in situations before where I have been eager, to say my bit, but I've challenged myself, but I'm not listening to understand, I'm listening to react. We've all been there, but that's just so important when you're thinking about listening well, and really hearing what somebody is saying, making them feel validated.
Thank you, Chair. So thank you so much, Anne, for your report, and it's great to see that the team is growing, and also that there are opportunities for staff to have their voices heard. I know we talked when I just joined the trust about access for people to speak up. And one of the things that I mentioned in another trust that I was formerly at was the use of an app. I don't know whether that sort of was able to, whether that was something that was explored and decided not to use. But I'm also quite conscious that there has been an increase in the number of people speaking up. So I'm wondering whether that would be another tool that would give people access to voice any concerns, or, especially with some of those stats being related to the increase in the sickness levels, with people suffering, reporting anxiety and stress as a concern. So I'm just wondering how we're expanding resources, because 17 freedom to speak up guardians is still one person to sort of, in terms of including digital technology into how our staff access support.
Thank you, Sue. We did explore it with a colleague, but it didn't go anywhere. I think this was with Sister Trust Coventry and Warwickshire have got an app-based programme, and they have commissioned like an independent company to come and do it, so it's bespoke for their staff. So we did pursue that, but that had been, I think that had been put on hold by their trust. But that's not to say that we can't explore it, because we do actually get a lot of email requests from companies asking us, that they've built systems for their trust that are unique to their trust. So yeah, it's definitely something. Now we've got more resource, it's something we can now go back to and refocus on. So I do think there is definitely a need for that. And maybe something about trying to integrate that with our existing systems, if that's possible. I don't know how that would be done. I'm not doing that at all.
That could be a discussion for FPP, because it will require resourcing.
It sounds as though it's something you want to be able to consider, look at issues here, what's its value, what difference has it made, and therefore we can have an understanding about how best to implement it, and therefore what we could expect as a consequence of doing so. But it sounds like that work needs to be done first, and then there'd be lots of different opportunities for how we can ensure that proposal is considered.
Had you done that previously when you raised now?
Well, Dave and I, a long time ago, we'd had early conversations, didn't we, about that, how that would look like, whether that would be integrated within our system or whether it would be something different. So we've done quite a bit of homework. But I mean, my vision would be, so at every induction, that somebody is able to download an app on their phone and take that away, because we do know that people do raise concerns away from the workplace. That would make that really accessible. And that would be brilliant, wouldn't it, eventually, if we could do that.
So could we set that as an action for you to do? You mentioned.
Yeah, definitely. Thank you. Thank you very much.
Thank you, Hannah. So we're on the short report on FEP.
Chair, I'll take the report as read. We've had two meetings since the last board, 21st of August and lastly on the 18th of September. Thank Winston for stepping in and chairing the last meetings. Thank you, Winston. I think a lot of the answers that I've got in my assurance report we've already sort of touched on, but I will summarise. I think, in terms of assurance, we're really assured on the work that the Trust has been doing on reduction in agency spend. We had some significant work, it's really excellent there, on the sort of gold standard, so well done, and long may that continue. We've also started to do a lot of planning for next year, a lot earlier, so which again is a real positive, and we've got some challenges which I can touch on shortly. And generally around some of the performance metrics that the focus has been on from the teams, the operational teams, seeing some real sort of green shoots coming through there. But again, we've talked about sort of end-to-end view, and maybe that's something that we need to sort of discuss on an ongoing basis. We're assured around the fact that the Trust will post its £2 million surplus that we're forecasting. But I think if we're sort of honest, we'll sort of scrape through. I think it's a huge challenge. We've still got half a year to go, and we're doing really well to sort of maintain the momentum to actually achieve that £2 million surplus. But it's not going to be easy. There's also system pressures that are play as well, and we just need to make sure that we get the right balance going forward. The biggest two sort of risks really we discussed earlier is our inappropriate out of area, and I think Rasheen focused on it earlier. The next piece of attention is around our bank spend, and really sort of honing in on how we can sort of look to reduce that. Vanessa's talked about what we're doing around the out of areas, so over the next few months it'll be interesting to see how that trend is firstly but then also then we bring it down to levels that are more manageable. It was great to see the waiting times deep dive at the last performance meeting as well, and sort of understood the issues that are around that. But yeah, it really is about sort of starting to focus in on next year, making sure that we've got the best possible run rate going into 25-26, and building a plan, cost reduction plan, which is sort of sustainable and delivered through recurrent savings. And again, reflect on the point that it's going to be challenging. We are running short, if not zero, balance sheet flexibility that we can throw at this. So the conversation that we've had about what is going to be different really starts to come into play. I know we're going through a time to do the strategy refresh, and I think that's quite timely as well. So all of those things need to start to come together and really start defining the plan for next year and beyond. Just to finish, we received the Business Development Partnership report. The winter planning updates are being reported into FPP, and also the Energy Preparedness Resilience and Response report, which is also in the pack for today. That was received by Finance and Performance. I'll take questions.
Any questions for Val and Leslie Getfield when they does Thanks, Val.
I wasn't really going to say much more than you already said there. We are a little bit off plan.
at this stage. We expect to be able to recover that just by the year end using the non-recurring, the blank funding flexibility. I think the other thing that we really don't know the impact on us at this stage is what happens around the overall system position. So I've done a little bit more, but at this stage, the overall B-Solids system has got a deficit of 61 million, and that's 44 million adverse to plan. That's basically around UHB's position. We do believe that's going to be improving later on in the year, but it's unlikely to be able to recover the overall position. I think David Melbourne at the ICB has been discussing with NHS England about what that means and what happens as a result of that. I don't think anything's happened that changes the position, but it could be that we'd be asked to do more. Doing more would be challenging.
I just to say that at this stage we are tackling this as a system as you would expect us to do. Notwithstanding the point that was made, which is that the majority of the system is UHB, but equally all roads lead to UHB from an application point of view as well. And so we've got to recognise that there is something for all of us to get behind this around this. And we need to link it to the work that we're doing around particularly the UC pathway, the pathway. And that's certainly a contribution that we as an organisation are committed to do, is around trying to ensure that we're supporting on what's happening on the pathway, both from a mental health point of view, from an emergency emergent care health. The most recent discussion we had as chief executives was that there are some elements of our financial recovery plan that we can now put in to support us closing that gap that you just described as. And we are also all committed to looking at ensuring that, particularly our spend around workforce, which of course makes up the most spend. So I think the work that we described that we're doing, we're already making sure that we're ensuring wherever possible we've got substantial staff and that growth is happening. But against that growth that we're driving down the level of agency that we're using, and we've done that very well, I think, as well. And so for us, it's that focusing around what we're doing around that, but equally being always sure that when we are making appointments that they're the right ones, and that we absolutely need those roles at this moment in time. So no particular ask at this moment in time of organisations to do more above and beyond those actions that I just outlined.
Are there any questions for
So not saying that in our research position. We haven't quite identified all of the savings that it's allowed science to recognise at the start of the year as a gap for that, which the system asks us to make good. I'm just wondering how we get to know that, that unidentified savings.
We haven't got specific ones within the sheet of the agencies. So agency has plans at the moment. Equally, interest receivable is above, but they're not really sustainable in the way that you go through. So we do expect to be able to do it with the time when we come to balance sheet. So as was said, I think Val mentioned, we're looking on to next year the proposals coming through. So we've had not a full range response, but we need to review those and see what we can do with those. But I think the thing is the two parts. It's about the overall part we play in the system around mental health and what we can do to improve that and the out of area. We're also working in a way where alongside the acute trusts and this flow through the patient, that's really something that we can make a real difference to. I think that it's nothing that's happening by this stage.
The problem, which is emotionally establishing SSRs that is doing better than there are other opportunities necessary, not in terms of saving for ourselves, in terms of the range of services that they provide to other partners in the system, whereby they could leave a greater savings with the system as well as ourselves.
Okay, there would be. So when we get into those discussions about the collaboration, essentially, opportunities for that, the biggest potential benefits in the short term is there is likely to be some taxation charge at this stage, the estimate is 160. In effect, the change of vehicle meaning that would be straight saving, or significant chunk of it. So there will be about 300,000.
Where are we in the process of discussions around the shares?
So the business case has gone to NHS England, they've asked us to provide the accounting advice around that, which we received seminars and recommendations. They said originally they would be released in July. They didn't start looking until September. That's the only thing they've asked us for at this stage. We anticipate getting something during October, understanding that. There's been further discussion with across the system with a view to how we go about identifying elements that are in there and looking at those various things. Steering group's been set up and something further than that. We do need to be clear about what the comms are around it.
It's always a concern, it's not just related to this trust, to other trusts as well, but struggles to find recurrent savings. We can find non-recurrent, but not recurrent savings. However, when the pressure is actually put on trusts, who are in financial measures with NHS, when there's pressure on them, you somehow then tend to find them, ironically. So is it just about more concerted effort being put into that particular area?
Well, I think the evidence of those systems and organisations that during this year that have gone into enhanced oversight is they haven't managed to find the money that they've been asked to find. They've found marginal elements of it. So, we are not alone. We happen to be a system that found a way of being able to put forward a balanced plan. Other systems found a way of being able to put forward an unbalanced plan and forecast that they believe they can achieve. Very few, I think, any are on track and on top. So, regardless of the level of oversight. So I'm not sure that that the idea that oversight lead to finding the money to draw the bottom line for the forecast versus some marginal gains. And there's some anecdotal evidence from colleagues in the systems that some of the things they've been asked to do have had unintended consequences as well.
And the difference is, if you look at this financially, you will stop spending money. There's implications that we want. We have to take a balanced position in terms of delivering quality and all that type of stuff. Coming in a financial position, you just have to clearly that is, well, it is good. We can always make savings. But we've got to try and get the overall balanced position. We're trying to spend money in the right way. All the things that we could do, we're going to pick up the thing like balance bank we talked about before, we really feel we're doing the right things.
I think we're clear about what we can do and what we ought to be focusing on. Do we think that that's going to lead us to be, the whole system to be in a balanced position? We've yet to. But it's looking highly unlikely to go. And I think we're also in a position that if we look at we're continuing to focus on performance and financial performance being the key things that we're asked to pay attention to. But actually, we've got a new government who's also saying quality does matter. We've got a number of inquiries and reports coming up that have been instigated during September that are already reporting, and some already reporting on the fact that actually quality and safety is of equal importance, or should be, and maybe even more important in some instances. So where we're heading could be a different way of operating, i.e. being supported to create that balance much more.
Sure. I guess my question, reason around that, is because your point is quite valid in terms of this new government. They make it very clear that there is no additional money, that's going to be pumped into the NHS. But what they're actually saying then is what we believe it may be about a reprioritisation, maybe around other opportunities where funds could be released. So I was just checking, have we done all that we can within our gift to say, okay, let's look at, where savings can be made on a recurring basis rather than on a non-recurring basis.
When we did the work with NHS in 2 years ago, the list of things that we came up with, we stacked up against that. There were a number of areas that we've done stuff since. We should mention before, we've significantly reduced the numbers of bases we've got in a long period of time, significantly ahead of agency, bank we could do more. So there are some things we want to do, but it's how we make sure we do this in the context of where we are with the things we're trying to do. So it's difficult to do everything that you need to do to achieve all the results and just try and get the right kinds of stuff.
Thank you. Thank you. If there are no other questions for Dave, we're moving on to the emergency preparedness resilience. It's not on the agenda as well, but I'm going to be asking Monica just to give us an update on Kevin Mines following your order. So, emergency preparedness resilience response, yourself.
I think the report's already been, I think it's been throughout.
It has, yeah, but I suppose just to say, you know, as part of core standards, it needs to come here and report and it to be assured that we have a plan. This is like the annual report that Louise pulled together for us. We submitted our core standards and we've said, and we get the terminology right, we have substantially compliant. I and myself and Louise have got a confirming challenge with NHS England and the ICB in a few weeks' time, or actually next month, just to go through all of those and just to check them out. So the report's here to be noted and to try and to give assurance that we've got a plan.
Are there any questions in relation to it? I think it's pretty straightforward.
Yeah.
Great, thank you.
Okay.
Monica, could you give us an update on
Yeah.
Kevin Mines?
No problem, thank you, Chair. So, Kevin Mines had a away half day earlier this week, where we talked about kind of strategy, governance, reporting lines. There's quite a number of things that we had to get through. I think the main points that I'd like to highlight as a result of those conversations is that in terms of governance, there are going to be some quite significant changes in the fact that actually all of us as board members of the trust are also automatically trustees of the charity. So ultimately we operate as a corporate trustee model approach, which means that in the same way that we have these board meetings and then we have a commissioning board meeting with our commissioning hat on, we also need to implement a charity Kevin Mines board meeting throughout the schedule of meetings on an annual basis, wearing a charity hat. So the committee has delegated authority to make various decisions, but some of those decisions, depending on their nature, would then have to come back up to this board wearing the charity hat for ratification and approval. So that's something that Kat and Hannah are looking into to make sure that those are scheduled in going forwards. There was a lot of talk around how the charity can support the trust strategy. We had an individual there from NHS Charities who gave us quite a lot of information about how generally NHS Charities operate, but also a lady from Birmingham Community Trust, that charity, who's offered Louise, who's our charity manager, quite a lot of support and mentoring, and the conversations around how she, on an operational basis, has dialogue with various individuals across their trust to make sure that what the priorities might be for the trust can then be embedded with some of the work that the charity also wants to do. So as a result of that, we agreed that actually the strategy for the charity, Kevin Mines charity, needs to be revised, but we wanted to do that in a co-production way. So Louise is going to go away and speak to various people across the trust and also service users and experts by experience as well. I mentioned earlier that as a result of those conversations, it was apparent that we need to have our own bath as well. So that's something that myself and Kat and Hannah will also be working on. And then there was an interesting conversation around conflict of interest, because we did have a incident earlier on this year where we had been offered support from an organisation who wanted to donate the funds from a golf day that they were taking part in to us and another NHS charity. However, the organisation's head office is based in Dubai, and then we had some challenge from our networks here about whether we would want to align ourselves with an organisation whose office is based in Dubai, and some of the ethical considerations that we need to take into account because of the perception that values may not align, and whether that should be a trust decision to take those funds or whether that should be a Caring Minds decision to take those funds, given that funds are limited. It was concluded that actually it is a Caring Minds committee role to make that decision, although if it was something where we felt that actually it would be detrimental to the trust reputation, and that would far outweigh the funds that come into the charity, it'd be something that would be escalated to this board for consideration. So that's the main point. So I don't think I've missed anything, but if I have,
There was just, they've refreshed the logo for Caring Minds as well, so that will be, you'll start to see the new logo that will be going out across the trust. It's fabulous.
it looks fantastic.
Comes up as a really fabulous piece of work there with Caring Minds, so that was the only thing.
Val and Patrick.
Thanks, Monica. I think I've raised this previously, just from my experience at the University of Warwick. If not already done so, it would be good to have a fundraising and ethics policy, whether it sits with Caring Minds, whether it needs to align with the trust. But I think if you look at what the geopolitics that are taking place today, the lines become very blurred, and I think we need to be very clear on where we stand as an organisation, where Caring Minds also stand. So I think it's a bit of due diligence, I think, needs to be done.
Absolutely, and that's something that was discussed during the day, and we are looking at aligning what we do as a charity with the NHS charities policy around that as well.
Great. Sorry, Patrick went first.
Yeah, that's fine. Yeah, so just one of the conversation that we had monitors about where positioning of Caring Minds in the organisations, and I think we concluded that we need to do the work on the strategy, but we believe that they will position at the moment in comms, but that might be a piece of reflection when we've done the strategy work.
Yeah.
Yeah, just going back to Val's point around, having a protocol or some sort of governance around just, the charities. Supports come forward from one of the networks, the LGBTQ plus network, to say they would be happy to, if you want to have their input to that. I'm sure the networks would help to support what that looked like, because they did feel very strongly and have conversations with them around that.
And again, we discussed the fact that we needed the input from various networks to frame the policy and how we shape it. So it's great to have their support.
Great, thank you. I'll take that back.
I'm sure I can lift Warwick, so I'm sure you won't mind the chat to use as a baseline to I'll ask a question.
Thank you.
I'm impressed. I'm impressed. It's great work that is done. It's great to have the away day and come out with some clear objectives and action plan and moving the charity forward. It sounds really, really positive. So I'm super looking forward to hearing more about the work that we're doing, but also obviously what we're doing is strengthening governance processes, reminding us as a board of our duties, I guess, as trustees of the charity. And I'm obviously speaking with Hannah and Kat to get those meetings, formalised meetings, into the diary. So fantastic, great. So look forward to the next update of progress on the Caring Minds. Thank you very much. So we've got terms of reference, which is pretty self-explanatory. Can we just take that and accept that? Yeah. Patrick, yeah.
Yeah, so given the conversation that we've just had around reporting to Caring Minds, is that what we want to keep in terms of reference? Because in the moment it's providing assurance to the board. That's what we
not to change it. Thank you. Sorry. Thank you for that. Okay. Living trust values.
Thank you. I sort of take such each of our values in their order really. And just sort of draw on some recent experiences that I've personally had. So we look at committed. I was really fascinated actually to go and visit two of our what I would call sort of niche services. And I went with John to the Youth First and Prosper teams. And it was actually fascinating to see a group of people sort of hidden away in one of our facilities, and just going to talk to them, it was just amazing to see the amount of how committed they were to doing the best for their service user cohort. And often these services aren't talked about very often around this table, but they're so important. I didn't even realise we had those two services, so it's just really great to see. But the people working there, they're very small teams, but really, I was amazed at the amount of sort of passion and commitment they had. So it's great to see that. Inclusive. We had our AGM last week, and I think the way it was framed, the attendees, it was great to see how that whole day and afternoon played out, and it was very much about we are in this together. We talked about our achievements, we talked about our challenges, we talked about some of the things that were really blocking us, and we had some robust discussions. I think certainly in the Q&A, and I think but it was done in a very inclusive way, I felt, and I was really encouraged, just to see that all coming together, and we are trying to do the best we can for our patient cohort, and I think that was a real sort of good message that came through throughout the afternoon. And then compassionate. I think Sue and I went to visit our dementia ward in
Juniper, sorry, Juniper.
Yeah. And again, I'm sure lots of us have been touched by family or friends that have been impacted by dementia. I certainly have. And it was just absolutely fantastic to see the care that's actually offered to people with that condition. And it's when you talk to somebody on a face-to-face basis, you don't really realise what might be going on in their minds, and it was fascinating to see the team and how they dealt with it. It was really, we were walking around and they actually took time to speak to their service user cohorts. It was really fascinating to see. It was brilliant. So that was my sort of recent experience of our trust values. But as I said at the AGM, I think the best part of my job is to go out and visit people, and you see it. But that's great.
Thank you. Thanks for that, Val. We're just coming on to the board assurance framework reflections. I just wanted to do a recap really of what we discussed today, just some things that I've jotted down, some highlights from the chief executive report, which and obviously Vanessa as well, the combined reports, and that was I just jotted down the level of vacancies that have actually come down and reducing the cost on agency, particularly a bit of focus around doctors in particular, bank staff. Still got some further work is being undertaken in that area, but it's already started and we're able to see green shoots going forward. And PwC and the SHMFT have also had that agreement. The paper's actually gone to both boards about moving in principle to an all-age service with one provider being the SHMFT. So we're looking forward to the next stages. It's talent. So there's a talent timeline, because obviously the contract comes to an end at the end of March next year, but we're on course. I also made some reference to the in relation to ICCR and the collaborative working with community care, collaborative hosted by Birmingham Community Healthcare Trust. And so I mentioned the work that's been in that area, and also it's positive to hear about the additional resource at Tamarind in terms of the HCAs, which has been
Graceland.
It's a Graceland, it's a Graceland, sorry. There, and also we had a long discussion around outer area placements and the work programme that's been steered by Vanessa and the team. It's still quite challenged, but there is a plan going forward, and we're hopeful that will produce the results that we're looking for from relation to that. We had some discussion around and be ready for discharge as well, and the collaborative work that we're looking to. We've already started with our local authority colleagues as well, and hopefully that will help to introduce turnaround, because we've got a designated team focused on that. We also spoke about the BAF report and the new BAF in readiness, which will come to the next board meeting, and then I actually made some reference around, so before going to that, there was a focus on the fact that on the BAF, the anti-racist discriminatory target hadn't shifted, and there was some discussion that we held around that, and looking at how we could pull together a report and bring it back to the board as well, and for Vida actually chipped in where that was concerned. Also mentioned in terms of IPPR waiting times, I think that was a concern for all, but work is underway to address this, because I think it's, at the moment it's at 104 weeks for waiting time for certain, and that's a deep concern, but I know that there's some targeted work being undertaken to address that and to bring that down. And then I talked about linking the IPR with the BAF and how it also relates to well-led in particular areas that we can actually focus on. Key Pest Assurance report, I didn't mention about that, the infection prevention report, which was really positive by Zalika. Some concerns were raised in that report, but she actually, and through what Sheen was saying actually she's been quite balanced in terms of some of the positive work that's been undertaken over the past year, and obviously since the increase of staffing within that team. Freedom to speak up was presented by Emma, and I think the takeaway from that was for her to undertake a scoping report for consideration for possible act for our staff to report their concerns. At this stage, we've just asked her to scope it and look at how that could potentially be implemented. We have the finance report as well that he said was slightly off plan, but hoping to pull this back so that we actually reach our agreed targets that we set out. We also talked about the system deficit, which we all know about, and our contributions where that's concerned. Finally, we have a positive report from Care Minds, which I don't need to repeat because you've just heard it. So those are the key highlights that I pulled out. From that, are there any areas that we feel needs to amend the BAF? Okay. At least we've actually gone through and identified if there is anything. Any other business questions from our audience? Members of the public?
I just wanted to go back to clinical supervision. So I know that we've had a strong drive for improving the uptake. We had the clinical governance yesterday, and I raised a concern that in urban areas, in terms of specialties, the uptake is quite low. That was based on the previous report. And interestingly, today I looked at my figures and they've increased exponentially, and that's probably because there has been such drive. That leads me to worry that because of the drive, it's not quality supervision and it's corridor conversations, and we're under this drive to improve our figures. And that leads me to think that that's probably due to our nurses don't get protected time, unlike other clinicians and professional groups. So I do think part of the solution would be to really think about, and I know we're not in a place or a position for nursing colleagues to have job plans, but I do think some elements do need to be planned into their working week, month, to ensure that we do have that protected time, and to think about what supervision looks like, that it is quality, that we do think more broadly around journal clubs, group supervision, action learning sets, that it isn't a debrief and can you tick that off please on your traffic light, because we've got a driver that says that we have to get improved targets. So, you know, we do have colleagues that really want to do well and, you know, please us and say we've done what we've asked. But we know that clinical supervision is meaningful and it's done well, and I do worry that if we're just driven by targets and not really thinking about what the clinical supervision look like, are you getting something out of it? Is it improving these factors? Is it improving care and quality for our service users? And so my plea would be, how do we think about protected time for colleagues, all colleagues to have that time that's protected to have meaningful supervision?
Shall I take that?
Yes.
So it's interesting, because that was the very conversation that Linda and I were having earlier when we were discussing this, and it's on our agenda at Safer Staffing tomorrow. It links back to our effective fostering, and we talked about that as well, didn't we? It's about how as leaders, and particularly how our ward leaders, our ward managers and team leaders, consider what a good week, day or month looks like for a member of staff, and what they're doing in terms of that long-term development of their staff, their skills and competencies. So in my view, I think we should be in a position to allocate protected time. I think that should be done on a team basis as well as for individuals, depending on what works and what's deemed reasonable. I think probably job planning isn't a good fit for nursing. However, I do think rostering in things like team meetings, regular supervision, clinical supervision should be in the plan. It should be on the road, and it should be in people's diaries. And there's almost a bit about how we audit the offer to our colleagues here, and how we audit the framing of that planning on the part of the managers and team leaders to properly have assurance, because I think you're right. There's certainly a risk that people are diluting what they're experiencing as clinical supervision, but reporting that as compliance. And I think there's a really good professional conversation for us to have with the wider group of heads of nursing. It is on our agenda, Safer Staffing tomorrow, so I'll speak there and pick it up.
Thanks, Liam.
Yeah, thanks, Bill. I've got a couple of questions of clarity, but I think I'll pick those up from Nessa directly afterwards. The thing that struck me was how prominent the staff sickness issue was at the People Committee. And it reminded me that over the years, the staff occupational therapy offer has come up quite a lot in terms of feedback from constituents to me. But I couldn't really see that in the papers much, so I was just wondering what assurances have the People Committee received about the re-provisioning of the staff OT service, which I think is underway at present?
Yeah, that has been reviewed, and we're going to bring in Patrick in regards to timelines of when that's going to be completed, when that review of Rocky Health.
Yeah, I've been looking at the timelines and getting back to you.
Okay.
Okay.
Yeah, it's under review.
Thank you. That's all. That's all I have.
Yeah. Okay, brilliant. So,
I just have any other business which is hot off the press, that we've had 3 more individuals or teams shortlisted for RC Psych Awards. So one is Dr. Salim, one is the Rare Dementia Service, and one is the QR project at Grove Valley.
wonderful. thank you, thanks everybody. That concludes today's board in public meeting. Thanks for members of the public. Did anybody want to say something?
I will it was a real pleasure to see how much clinical service was kind of discussed. It's part and parcel of my job, and live reports about right care, right place. Pleasure to watch. We do have similar discussions in our board, but it's good to see how we operate in different board structures. Thank you for giving me that opportunity. Thank you.
It's great that you came along. Thank you very much. That's it. Unless anybody else has got anything to say. Thank you. Thank you, everyone.
Thank you.